Good morning, everyone. We were making jokes about how the early bird gets the worm, but in this case, it's the early faculty, staff, and learners get the coffee, pastries. So for those of you who are joining virtually, this could be you too, having snacks. So good morning, everyone. Welcome to our second grand rounds of the year. Thank you for all of those in person and for those who are joining virtually. And as we are holding this grand rounds, at least part in person, we do want to take a moment to acknowledge the Stanford University land actually sits on the ancestral lands of the Mokwame and Ohlone tribe. And this land continues to be of great importance to the Ohlone people and consistent with our values of community and inclusion. We have a responsibility to acknowledge, honor, and make visible this university's relationship with its native people. And land acknowledgements are always important, and especially so when we're having a conversation around health equity, where it's one of the most visible ways that we see inequities is in the land that we're literally sitting on to be able to have this conversation. So for those of you who don't know me, I'm Ananta Adel. I'm a peds endocrinologist, and I'm part of the DEIJ committee for the department. And it is, to say it's my absolute pleasure and honor would be an understatement to introduce Dr. Joyce Sackey, who's a clinical professor of medicine, associate dean within the School of Medicine, and is the inaugural chief of equity, diversity, and inclusion for Stanford Medicine. And in this role, Dr. Sackey has been designing, developing, and overseeing Stanford-wide initiatives in an effort to advance inclusion, excellence, health equity, and justice in partnership with actually the leaders at the School of Medicine and the leaders at Stanford's Adult and Children's Hospital. So, no small task. And she has also been supporting the existing diversity, equity, inclusion efforts that are underway at Stanford and actually across all of Stanford Medicine's enterprises, and provides oversight for the implementation of recommendations issued by the Joint Commission on Justice and Equity. So just from that little blurb, and I really synthesized all of her decades of work, you can see the amount of institutional impact she's already had. So she's had this long, impactful career where she's operationalized equity to support institutional changes at this institution and all of her prior institutions. So I want to take a moment to thank Dr. Sackey for all of her decades of advocacy and work and sort of role modeling, and we'll hand it off to you. Thank you so much, and we're excited to learn.
Thank you. Thank you so much for that really generous and wonderful introduction. It is such an honor to be joining you today, and I just want to thank the leadership of the department and the diversity and equity inclusion leadership for recommending me and for inviting me today. I am going to be talking on the topic of advancing health equity and specifically discuss supporting good intentions with the measurement and accountability. And I use the words discussing intentionally because I'm also hoping this would be a conversation. So my goal is to share a few slides to sort of frame our conversation, but please feel free to post questions in the chat. And then I certainly hope I'll leave space at the end to be sure that we are engaged in a conversation. So my educational goals are to provide an overview of the body of evidence documenting child health disparities. Many of you know this already, but just sort of to touch on, identify the key drivers of disparities in child health, and then describe a strategic approach to advancing health equity with a specific focus on what we're doing here at Stanford Medicine. And then finally, last but not the least, I'd like to talk about a measurement-driven approach to eliminating disparities and advancing equitable patient outcomes. So child health disparities have been documented across multiple conditions. As you know, right from birth, infant mortality, as well as maternal mortality has disparities that we're going to talk about in a minute. Low birth weight, we also know, which has disparities as well by race and ethnicity, have associated with it long-term adult health outcomes. So really, the work that we're doing across Stanford Medicine really to advance health equity really begins with Stanford Medicine Children's Health. In fact, the interventions that we do here will have implications for decades to come. And then chronic conditions, as an example, asthma has been shown to have disparities again related to environmental factors, such as pollution and others. And then mental health, behavioral health outcomes have similarly been shown to have disparities. And I wanted to just spend a minute on that last bullet, in a couple of slides. So first, childhood disparities begin right at birth. And so here is data from the CDC showing infant mortality in the US. This report came out in 2020, and it's through represents 2019 numbers. And as you can tell, non-Hispanic Blacks have the highest infant mortality rate. However, it doesn't stop there. The fact of the matter is we have other minoritized groups that similarly have high rates. So here's the next column. There's the non-Hispanic Native Hawaiian or Pacific Islanders at 8.2. And then the next column shows non-Hispanic American Indian and Alaska Native. So as we talked about just a minute ago, the importance of really thinking about Native populations. Hispanic populations have infant mortality rate, which comes up 5, and it's, I want to point this out specifically because in a couple of days, we are in fact going to be celebrating Latinx Heritage Month. And then you see the non-Hispanic white at 4.5. And I want to point out that even at 4.5, or the average, is not acceptable for a country that spends more dollars per capita than any other country on the planet. So infant mortality is tragic regardless of the group that you're looking at. And it's especially tragic that we have these disparities as well. So this is infant mortality by state. I thought I would show you so that you could see where California sits. It's about 3.9 per 100,000 1,000 births. So we're certainly not the worst. As you can tell, some of the worst states are actually in the southern part of our country. But certainly every state has work to do in this area. Now, if the infants survives, they may not actually have a mother to raise them, because as you know, our maternal mortality rate is also especially high among developed countries, in fact, the highest among developed countries. So this graph, just to orient you, shows the trend between 2019, 18 through 2020. And as you can tell, sadly, it's actually growing. Maternal mortality rate is growing in this country in almost every group. I want to point out to you the columns with the highest heights here. So non-Hispanic Black again, really rising over time. And this is not clear whether this is related to the pandemic we went through or more. 2020 is, as you know, the sort of very beginning of the pandemic. But we're yet to fully understand why the rise after really years of this being in the news and talking about doing work to reduce it. So a life course is literally set from birth. And so child health disparities have also been associated with adult chronic conditions, cardiovascular disease, metabolic disease, including diabetes, insulin resistance, obesity, really the seeds are sown literally in childhood, respiratory disorders, behavioral health outcomes, and depression and anxiety. And I mentioned earlier, I wanted to spend a minute just focusing on behavioral health outcomes and depression and anxiety, because I think it's really similarly going up, and it's worth focusing on this. So this is, I know it's a busy slide, but if you want to sort of delve more into it, this is an article that came out towards the end of last year in Pediatrics by Hoffman et al. And it shows you that just about for every single condition that is documented here, whether it's ADHD, behavioral conduct problems, depression, anxiety problems, even autism spectrum disorder, suicide, all of these have shown differences by race and ethnicity. And then sadly, when you look at the last bullet there, which is medications for mental health problems, it's actually folks who are in minoritized groups, such as the Black community, also show that the number of people who are actually being treated for these conditions is lower. So at this point, I wanted to introduce the working definition that I like us to sort of think in our conversation for health equity. And I've taken the CDC definition of health equity, which is the state in which everyone has a fair and just opportunity to attain their highest level of health. There are several other definitions, but I feel like this sort of gets to a couple of the things we're going to be talking about later on. So it says that to achieve this requires ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and health outcomes, in other words, social determinants of health, and then eliminate preventable health disparities. And I thought it would be helpful to also share with you a definition that we adopted here at Children's Health and this slide is courtesy Dr. Grace Lee, who led a discussion on a shared definition of health equity for Stanford Medicine Children's Health. This was in the context of creating our inaugural position for a chief health equity officer who will be embedded within our healthcare delivery system. So as you can see here, it says that Stanford Medicine Children's Health defines health equity as advocating and ensuring that all patients and families have a fair and just opportunity to achieve their full health potential. And to do so, we commit to partnering to understand the root causes and to eliminating preventable and remediable health disparities. So what are the key drivers of health disparities? All of you know about social determinants of health, but I thought again, to sort of frame this, I'm going to use the Healthy People 2030 definition. So social determinants of health are the conditions in the environment where people live. People are born, live, learn, work, play, worship, age, and I would add die, that affect a wide range of health, functioning, and quality of life outcomes and risks. And this schematic here, I think, really helps to sort of bundle them into 5. I tend to remember things when they are 5 or less. And so you could see here that social determinants of health can take the shape of access to education or quality education, all the way to access to healthcare and I would say quality healthcare, economic stability, obviously, and then social and community context in which people live, as well as the built environment within which they live. And broadly speaking, this will sort of encompass all the different ways in which non-health needs can actually impact health outcomes. And in this schematic from the Kaiser Family Foundation, I think helps to sort of see the relationship between racism and discrimination and the social determinants of health. So again, you have the pillars of the different social determinants of health, economic stability, food insecurity, and so on. And if you then superimpose on it racism and discrimination, that actually makes everything worse and obviously includes health and well-being. So think of just the cross-section of groups that are subjected historically to acts of racism or discrimination. And then on top of it, think about, for instance, socioeconomic status. And that impact is going to be far worse than if you look at groups who typically don't experience one form of discrimination or the other. So we've been at this work for decades, reducing disparities, not only in child health, but in adult health. And this article actually in Hospital Pediatric sort of summarizes the work to date, that research and advocacy initiatives over the years have really targeted health disparities through the lens of preventative and primary care, focusing on addressing social determinants, improving health delivery, and establishing a medical home in the outpatient setting. Don't have any qualms at all with this. I'm a primary care physician, and so I believe that primary care and preventative medicine both have incredible role in addressing social determinants of health and helping patients attain the best health possible. However, if we adopt a health equity lens in and out of our hospital setting, we will see the healthcare disparities exist along this entire continuum of care for children when they're admitted to the hospital. It starts before they come to our gates, but it also can impact what they bring from the community can actually impact their hospital course. And there's plenty of data to actually document this. And it will continue long after we've discharged them as well. And so I have to say, while we've done tremendous work, including incredible work that has happened right here at Stanford Medicine Children's Health, especially in the outpatient setting with absolutely dedicated, phenomenal physicians who are doing the best they can to provide high quality care to our patients in the community. We need to double up our efforts to address social determinants of health when patients are hospitalized as well, because that's an opportunity for us to actually effect changes in the post-discharge space and minimize readmission and hopefully keep kids at home, keep kids and their families at home. And so the American Academy of Pediatrics has sort of adopted this schematic of how to really embrace both the medical determinants and the social determinants of health within the hospital setting, and to ensure that we're doing our bit to set children and their families up for success. And I know this is a very busy slide, but again, it's really bringing together everything I've talked about so far, all the social determinants of health, as well as all the medical determinants of health that you know of, that you very well know, and really making the argument that hospital systems, and I would say especially academic medical centers, have a major role to play in really making sure that we have a full continuum of interventions to advance health equity. So bringing it home here at Stanford Medicine, as you know, Dr. Lisa Chimlin and Dr. Elise Adams co-chaired one of our 4 action planning work groups that emerged from the Commission on Justice and Equity work. And they came up with really ways in which Stanford Medicine as a whole can really play a key leadership role in advancing health equity nationally and internationally, because of the strengths and resources that we have really in the tripartite mission. So whether it's our research and our ability to really contribute to new knowledge through discovery science, patient care, absolutely top-notch patient care delivery that we do here. Obviously, we are in the business of education, and we are in the business of really literally contributing to the workforce across our country, as people really, when they train here, find the country, and I would say even the globe. So really compelling set of recommendations coming out of the Health Equity Excellence Action Plan. And at this point in time, we're incorporating those recommendations into the strategic plan that is actually near complete for the CEDIO, Chief Equity Diversity Inclusion Officer. And I can't wait to actually get on the road soon. We're about to start our socialization plan. So I'll be spending more time in detail to get your reaction and input into the strategic plan. But I wanted to spend a couple of minutes just focusing on the tripartite mission. So when it comes to our research mission, health equity can literally be a cross-cutting theme that really begins from the basic science work all the way to epidemiologic work and work that we do in policy setting. Health equity is a strategic goal as well. And many of you know that we are in the midst of the ISP refresh, and our own Dr. David Mass is on the subcommittee on health equity, along with Paul Maggio from Stanford Healthcare. And health equity is a strategic goal now, and it certainly will be more prominently featured in ISP 2.0. And so as a strategic goal, then health equity is a lens through which one can view all research activities and outcomes. And here are a few examples about how we can really transform the environment of knowledge discovery and science. Diversifying our biomedical science workforce is critical to achieving our goals here. Representation matters, and it matters in biomedical science research. I apologize, I hear ambulances outside, so I hope it's not distracting. Promoting an inclusive culture so that the diverse work team that we bring together actually feel a sense of belonging, equally important. And then, of course, it's been shown that advancing team science as opposed to, well, not as opposed to, in addition to single PI research model, can in fact help diversify the research workforce. And of course, we need to make sure that diversity is absolutely represented in research subjects in our clinical trials because of the import of the results that we get from these clinical trials. We want to make sure that it's representative of our population. And then using public health and population science research to address the health needs of populations and communities is really something that we're poised to really advance and lead nationally. And I like to add emphasize the last point that we can also encourage absolutely new areas of inquiry to include research that fundamentally advances health equity. So take, for instance, obesity, which I mentioned earlier, has all the disparities there, and it sets children up for adult complications later on. This is an area that, as a country, we can do more to really understand obesity, come up with interventions that work, that are have minimal side effects, because as you know, we've gone through a cycle of medications that ended up having to pull off the market because of complications, but also most importantly, medications that are affordable to communities that are underserved so that we can really treat obesity. But it will even be better if new areas of inquiry can help to really generate ways in which we can actually prevent obesity from childhood in the first place. And then in terms of our clinical mission, I just listed here a few strategies that will be both at the provider level, but also at the level of the health system. So for instance, mitigating implicit bias, which we know has an impact or contributes to social, health disparities, will be important. So whether it's through training, self-reflection, engaging in discussions that allow all of us to sort of learn how we can mitigate our own bias will be important. Screening for social determinants of health, as you know, we're doing this or doing this in a pilot fashion, doing screening for food insecurity, with a goal that we will be turning on the social determinants of health wheel more broadly at children's health. Very exciting. Leveraging IT to do so. And then really making sure that we work at the system level to stratify performance data by race, ethnicity, language, access, socioeconomic status, and insurance status. And of course, when we get to ask, because we care phase 2 and we have sexual orientation and gender identity, stratifying our performance, safety, and quality data by those parameters will be important. This is really an important takeaway in my talk, that we assume a lot in medicine that we're doing well by our patients. And we're doing the best we can. But without the data stratified by race, ethnicity, language access, socioeconomic status, and other dimensions that we know have been associated with disparities, it will be very hard for us to say for sure that we are, in fact, having equitable outcomes for all of our patients. So we should embrace this. We should not be afraid of it. We should really be transparent about this data. And then once it's clear, make sure that we are actually driving specific quality improvement measures that tailor to those areas, those gaps, and making sure that we are addressing what impedes folks from getting the equitable outcomes that we're hoping for. And then the need to maintain a dashboard of metrics that easily allows us to track our progress, I think it's important. Finally, we need to align our incentives. And reward our providers, the providers who really are working so hard to care for patients in vulnerable communities. We can't have it be that they have to choose between doing what is right, what they're passionate about, versus actually having a viable financial system. So we need to really incentivize not only individual providers, but teams and units to provide high quality care for everyone, but especially to our vulnerable populations. And then at the population level, the importance of partnering with our community cannot be overstressed. So the community know best how we can work with them and help them. They know where the assets are within the community. They know the resources are. However, we also can play a role as we interact with our patients, whether it's in the outpatient setting or inpatient setting, to really do the matchmaking and connect them to the resources that are available as they need them. As a result of screening for social determinants of health, it would be more harmful to screen for social determinants of health and not use it to actually intervene. So this is critically important. And the partnership with the community is really going to be the linchpin for us to do this work. And then another strategy will be to design disease-specific, take for instance, diabetes, asthma, or population-specific interventions, take for instance, children with disability, that allows us to really hone in on particularly vulnerable groups that we care for and ensure that they have the wraparound services throughout the continuum of care. And then we're well poised to contribute really to the implementation science efforts, because right now, a lot of healthcare delivery systems across the country, as you know, are working to close the gap between evidence-based healthcare delivery science and real-world practices. And I think we can play a lead role in doing so. What we already know works is not always applied in our healthcare at the bedside. And so really pushing that last step of applied science, I think, will be incredibly important part to making sure that we get good outcome. And then we can be a leader in the really relatively emerging science on social determinants of health, because right now people are doing, but we can actually study and actually have ways in which we can say this is an evidence-based approach to incorporating social determinants of health. And this really can help us to inform not only our local, but regional and national policy setting agenda. And then last but not the least, we do this work and we can do more of it to play an active leadership role in advocacy for health equity, especially on behalf of vulnerable communities. When Stanford speaks, people listen. And so we can leverage that platform to ensure that we are playing a lead role in advocacy across the country and globally. And then, of course, educational mission. I mentioned earlier that we are in a business of training people who are literally fanning the globe after their training here. And so ensuring that our students and trainees, while they are with us, are exposed to the clinical challenges of caring for patients in these vulnerable communities and making sure that they have the tools so they can effectively work in this space and not get burned out when they leave. And, you know, I've encountered students and trainees who have the best intention of serving underserved communities. And after a while, they get exhausted from the sort of under-resourced conditions in which they work. If we can equip them not only with the tools that allow them to work effectively in these conditions, but also do the advocacy I talked about earlier to make sure that these communities and the teams that are doing work within these underserved communities are really supported, then it will be a win-win for all of us. And then, of course, we have the incredible privilege of developing future leaders who then will become champions in advancing health equity through all the ways in which we talked about. And I can't emphasize enough the importance of aligning our incentives with our values and making sure that the work that people are doing also counts towards the currency that we understand in academia. We in academic medical systems understand promotion. We understand advancement. And what better way to make sure that we are incentivizing teams to advance this strategic goal than to make sure that the work they do is rewarded through the promotion system. And then finally, transforming the learning environment so that as we work hard to have a more greater representation at every level, that in fact, when people come into the environment, they thrive and that they experience a sense of belonging and they can really literally live and feel a commitment to equity, diversity, and inclusion. So finally, I want to just wrap up by bringing all of this together to, as I mentioned at the beginning, hoping to share with you in the coming weeks the details of the Chief Equity, Diversity, and Inclusion Officer strategic plan and the implementation, which took really not only the health equity excellence recommendations, but also took recommendations from other 3 action planning work groups that emerged from the commission. And really what we've done is we've really synthesized it and integrated it into these 3 pillars, working hard on workforce diversity and development because representation matters and is in fact one of the strategies for reducing health disparities. So doubling down on our efforts to recruit at every level and to retain once people come, providing folks with the education and training so they can have the tools and skill set to drive towards our strategic goals will be an important part of workforce diversity and development. And then in terms of culture, really making sure that we have inclusive practices and that we have policies that are equitable, that we make our mission and values really not a secret, but explicit to those who join us. And then when individuals, I should say those who join us and those who are already here, because I'm not sure that if I go around and ask people to tell me what our mission and our values are, that, just stopping people on the street, that they would be able to just blurt it out off the top of their head. And so really making this explicit to all of us within Stanford Medicine and outside of Stanford Medicine, and then not being afraid to hold people accountable if their behavior does not align with these values that we profess to have. Because if you don't have accountability, then it actually is meaningless because people are going to very quickly see through it and see that you're not really fully committed to those values. And then finally, we talked extensively about health equity today, and the 3 work together. We can't have one without the other. So I'm very much looking forward to our conversation this morning. And I'm also looking forward to engaging with you in the coming weeks and months as we implement a strategic plan that would ensure that we achieve inclusive excellence and health equity for all of us. And I started with my educational goals, and hopefully I've addressed them.
Thank you so much. We're going to start circulating some questions around. Is there any specific place that anyone wants to start off the discussion and question section? So while people are warming up, and online as well, I'm keeping an eye on there. So if I could start with one question, which is that as I'd mentioned earlier, for quite a few decades now, you've been working on institutional level changes. And so are there suggestions that you have for individuals who are either thinking of starting or maybe don't have the ability to influence an entire institution yet? Are there places where you think that the average person out there listening to you, who's exceptional because they're here in Grand Rounds, can start the work on equity? Where would you suggest they go?
Yes, thank you so much for that question. It's one of my favorite questions. Some of you may have seen me use this 4 I's of anti-oppression work as a framework for how we can work at every level. So the first I is individual level. The second is what we can do interpersonally with each other, and I would add that the work we can do as a team. The third is, as you refer to, the institutional level work that we engaged in. And then the last I is ideological. So, I mean, we know that the work that we do can be significantly impacted by laws, legislation, and what is going on societally. And right now, I don't need to tell anybody in this room or on Zoom that we're facing some significant headwinds as a country. And we're relatively fortunate to be living in California, where so far we have not received edicts that we should stop doing work in diversity, equity, inclusion, or health equity, God forbid. But the fact of the matter is things are happening nationally that a threat to any of the states in this 50 state union is a threat to all of us. And so those 4 I's really hopefully emphasize the fact that we can do work at every level. And so for individual, I'll give an example. I think that each of us, whether we are patient-facing or in the research sphere or as a staff person, can learn about how, whether the work we're doing individually is one that actually has an equity lens. And so to just make sure that wherever you sit, to ask the question, if you happen to be at the decision-making table, and even if you're not at the decision-making table, to ask the question of the decision makers, are we using an equity lens in the work that we're doing? That is the personal level intervention or advocacy work that I think it's important. And as I mentioned earlier, representation matters, right? And so also making sure that whether we are recruiting or we are working with teams, that the teams are representative and they are not only representative racially, ethnically, but in terms of all the dimensions of diversity, including sexual orientation, gender identity, gender expression, and so on, ability, but also making sure that we are including the voices of the community. That's part of the representation in the work that we're doing. So the next time somebody's suggesting a policy or a new intervention or an outreach to the community, you as an individual and you as a team, as a unit, can ask the question, are we using a health equity lens in the work that we're doing? And then, of course, institutionally, this is the work that I'm relying on all of us to do. I can't do this by myself. And so I may be an institutional leader, but I very much am looking forward to working with all of you as we work across the institution to advance health equity. So I hope this is giving people a sense of what they can do on the individual level. I could also say, I mentioned that taking the implicit association test, it will be important for each of us to reflect some on what biases we have. If you're a human being, chances are you have unconscious bias.
Thanks so much for that answer. Questions in the audience? Yeah, Becky, thanks. I'm just getting a mic to someone. Joyce.
Hi, Becky.
Joyce, it's so good to see you. Thank you so much for the work you're doing and really appreciate partnering with you in education and all of our missions. As you know, one of the key things that affects our learners and our residents and fellows, students, residents, and fellows is mistreatment. And over half of the mistreatment concerns are around racism and other ways in which our learners who are underrepresented in medicine are marginalized by our systems and by our people. How do you balance holding people accountable, and yet we are all learning as a country, as an institution, and really promoting growth mindset of how do we do the individual work for us to learn and become more clear with our, or using better language, using better actions. Anyway, how do you balance those two between accountability and us growing and learning together?
I love this question, Becky, and thank you for asking it. And like you, I'm a medical educator, and so first and foremost, I'm an optimist that when you educate and people understand and have the tools to behave in a way that is consistent with our values, that they will behave, act accordingly. So first and foremost, absolutely is the education piece. And I as I'll be sharing the strategic plan with different teams, and I think Becky, we probably will be meeting with you in the context of educational leaders, that having this education be accessible to all, not just those who choose to take it, will be critically important in the work. I think, though, that there are ways in which we can hold people accountable that is not only through, let's say, reporting system. Reporting mechanisms will be critically important, as you know, important for students, important for residents. But I think in addition to that, we need to find ways in which all of us learn to speak up. Because what I've also encountered is that people typically don't want to say something at the time when they know that witnesses, or allies or upstanders, however you want to call them, may have witnessed an incident, but they don't say anything. So the person who has just been victimized is probably tongue-tied and doesn't know how to advocate for themselves in the moment. But what about all the people who were there who saw the mistreatment occur? I think if we all strive towards really a speak up culture, then my hope is that we will not get to a place where things escalate and people have to actually have to report and have, you know, a full investigation launched, but rather there will be ways in which we actually speaking up for each other. You know, even at my you know, I want to say my age, but you know, I don't want to. But I've had a long life living as a Black woman, and there are times when I find myself not having the energy and wherewithal to speak up when I experience microaggressions. There's sometimes that I'm able to say it, and I have more words to be able to speak up, but I don't always. You know, I'll give you a small example. I was attending a major medical conference out of state, and I checked into the hotel, the main headquarters of the hotel, and it was a long line of us who had clearly were just coming to check in. And individual after individual was addressed by, hello, doctor, this. And I get there and he looked and he said, hi, Miss Joyce. And this is after a long flight. I was absolutely exhausted, just didn't have the energy. But I said, you know what, for the sake of whoever may be in this line, I have to speak up. So I leaned gently and I said, you know, I just want you to know that I'm Dr. Sackey, not Miss, you know, oh, sorry. I mean, it happens and it's a small thing, but just imagine this happening repeatedly. And imagine then taking it back home, bringing it back home, a resident who is walking into a patient's room, and rather than being addressed as doctor, they are being addressed as, oh, are you here to, I don't know, remove the bad pan? Are you here to anything but being a doctor? It can erode at people's confidence over time. And so speak up culture, but also encouraging ourselves to speak up even when we are tired and too tired to speak up. I think all of these are small ways in which we can transform the culture. But we also need the reporting mechanism. Right now, there's gross underreporting.
Thank you so much for that answer. Do you have
Thank you, Joyce. As you're developing this reporting mechanism, can I advocate that it's across all of our silos, medical students, residents, fellows, faculty, staff? I think there's so much we can learn, because I think there are a number of trends we can learn from each other about where education should go, where structure should go, like how we continue to work on the culture. Thank you.
Thank you.
Thanks. I'll pull in a chat question from the chat. There's a few, but the first one is, what can our system do when equity conflicts with our financial status? So as an example, the difference between hospital and Medi-Cal and other insurances. So if you have but in general, just the conflict between equity and finance.
Yeah. Oh boy, that's a very easy answer. No, I'm just kidding. That's a tough question. Absolutely tough question. And what did they say? No bottom line, no mission. I mean, I totally get it that we can't. We need to focus on the mission, and we need to really be mission driven. But we can only do that if we do it with a sustainable financial model. That said, I think if we are explicit about health equity as a goal and increasing access to the high quality care that we provide, I believe that Stanford can come up with innovative ways of taking that work or making really extending that healthcare, high quality healthcare to communities that are vulnerable. We have technology. We're in the middle of Silicon Valley. Telemedicine, which has really had an uptick in the midst of the pandemic, is a way in which we can bring the high quality care and really the incredible workforce that we have here to our communities. You're doing that already. So I know that I'm preaching to the choir. We need to do more of that. And then when there are complications in the community where only we can uniquely tackle, we need to make sure that people have access to care here within the walls of Stanford Medicine as well. So we can't have a situation where we say, well, you're going to cost us too much, so you stay right there in the community and never come to us, right? Because then the community is not going to trust us. We need to give them access to the sort of really complex interventions that only Stanford Medicine is uniquely set up to do. But there's no question there's more we can do and keep kids and their families within the community and come alongside those community people who are working in the community to provide care. So technology, digital health, all kinds of things that are actually happening globally. Literally having cell phones, giving people cell phones in remote areas in Ghana allows them to have access to care that otherwise they won't access. So why can't we do it here?
I love that answer. Thank you so much for that, because it gets at the feasibility and the fact that it's doable here, right? So thank you for that. There's another question, thanking you for your that's not the question, that's a statement, for the wonderful grand rounds, but also a follow-up question on community engagement. And specifically if there is best practices within healthcare systems, outreach efforts to underserved and marginalized communities so that it's sustainable, it's consistently delivered. You sort of talked about this. Can you hear me?
Yes.
Okay. It just sounded quiet here. And specifically how you see Stanford Medicine, SCH, and LPCH kind of all working together to accomplish that goal of really coming up with healthcare practice systems to outreach to families.
Yeah. Well, I mean, this is where I totally agree with Becky's earlier comments that we can't keep working in our silos. We need to learn from each other. And there's no area that is even more crucial than when it comes to really community partnership, right? At the end of the day, community, they know all of us as Stanford. So whether you're coming from Stanford Healthcare or Stanford Medicine Children's Health, or even sometimes the university, I understand, they're going to say, oh, this is Stanford. Stanford came to the community. And it also will be incredibly inefficient and exhausting of the community if we insist on doing work in our silos and engaging the community. So absolutely, this is an area that we can align. And my gosh, we are well poised, because what other system around there has a School of Medicine known for incredible research and just contributing to discovery science, a world-class children's healthcare delivery system, and an adult healthcare delivery system? I mean, if you put the three together, there's nothing that we can't do with the community, and emphasizes with the community. And so one of the best practices that I think will be important, that I've seen that actually has worked, is to actually think about solutions in conjunction with the community. I don't mean having a single community member sit on an advisory board here on our beautiful campus. I mean, going to the community and asking them how we can address the challenges they're facing, and then coming alongside them and hopefully using our name in a way that actually bolsters their advocacy for themselves. I think that has been one of the better ways in which you can sustain the relationship. Not showing up in the community when we need something, just showing up the community because you want to recruit people for your clinical trials won't work. But really being there and working with them like you did in the pandemic. I wasn't here, but I heard about how you were in the community, vaccinating kids, educating, testing, doing that, but doing that in a way that is everyday work, so that the community really, literally, when they think of Stanford, they think of, oh, this is the partner that is always here, not the one that shows up when they need something from us. It's hard work. It's hard work. And the hardest piece of this is actually building trust. And so Dr. Anthony Fauci said, trust is earned. So when you have communities that are mistrusting you, you can actually work to earn that trust back. But it's hard work and it has to be sustained work as well.
Thank you.
Good morning, Dr. Sackey. so energized by your grand rounds this morning. My name's Lynn Huffman. I'm in the Developmental Behavioral Pediatrics division here at Stanford. And I wanted to return to the point that you made about telehealth practice as a way of distributing healthcare equity. And just to, I guess, comment, maybe it's a question also. One of the things we've learned this year is that many insurance programs, including Medi-Cal, are no longer reimbursing for particular components of healthcare delivered by telehealth. And that's a really discouraging sort of evolution of having demonstrated they were able to deliver healthcare in this way, in this very capable, goal-oriented way, and then to have the insurance companies kind of turn around at the end of the pandemic and say, okay, no more of that, just let's get people back into clinic. So again, I guess it's the balance of the drive for healthcare equity, and then the financing of our healthcare system and how they work at cross purposes, particularly in the realm of telehealth.
Yeah. Oh my gosh, I didn't know this, that that really seems like it's not forward thinking at all. And,
No.
and I think this gets to the importance of advocacy. And I know that colleagues like Sherry Sager do incredible work with governmental relations and keeping an eye on regulations. And I think Sherry shared, I think she shared publicly that she may be retiring, and I think she's going to have big shoes to fill. But this really underscores the importance of really advocating, whether it's with intervention. This could be a way in which this has been shown, this data, that this works. We also know that mental health disorders are going up. The incidence is going up, not down. And this is not a time to actually abandon use of technology. So sorry to hear that, but I hope it's charging some people in the audience to shoot out letters to their representatives and do whatever you can to make sure we are advocating for children and their families.
Thanks so much for that answer. And you came back to your 4 eyes there. You just gave an individual solution for what you, I'm actually going to jump ahead on one of the questions that's listed because it's parallel to the comment that was just brought up. But the question is, what strategies do you suggest for dealing with the cancellation of DEI initiatives? In a few places, it's not necessarily here, but as you mentioned earlier, a threat to one state is a threat to many and all. So I think the question is that sometimes there is structural and sort of things that are outside of our sphere of control, but they're directly influencing what we do, telehealth, and now this education. So strategies that you might suggest.
Yeah. Yeah, I mean, I guess one word, vote. I mean, seriously, I think our civic responsibility has not been more important in the last few years. I just feel like when I look at the trends in things being rolled back, the Dobbs decision, the decision in some states to actually interfere with literally care that is happening at the level of the patient and doctor, it's incredibly important that we vote and we choose carefully who our representatives and leaders are. And so I think that, I also find that I'm privileged in the sense that I worked in Massachusetts, the state that introduced universal health care before we ended up getting our comfortable health care. And now I'm in California, where the policies are in general friendly. And so let's make sure that we're reaching out to our colleagues who are living in other states. When I've gone to WMC meeting, I've literally had like support sessions with people who are living in states that perhaps they are state institution, public institution, they are dependent on state funds and have had to roll back, and just encouraging them and encouraging everybody to vote. But also, here's one thing that I learned at the last WMC meeting that actually was the group on diversity and inclusion of the WMC meeting in Palm Springs recently, that we know how to talk to each other about the work we do and why it's so important. We have not done as good a job of educating the public as to why diversity is important, inclusion is important, equity is important. Health equity literally should matter to them, right? It should matter to you whether you live in the urban setting or rural setting in this country, because we know that there's disparities in. So doubling up on education of the public of how, in fact, this should matter to them. We're not trying to be woke. This is not about being woke. This is about saving lives. This is about making sure that children live to see their first birthday. The mothers can live to take care of their children. If we can really bring it to the level of the layperson, I'm convinced, again, the optimist in me as an educator, I'm convinced that people are going to do the right thing and really examine the policy platform of the individuals for whom they vote.
Thanks so much. Any other questions in the audience? There's one more in the chat, and it's around trying to make sure how we connect the fact that there's sometimes siloed groups within a human sort of lifespan. So the infants have a fair amount of priority, and the adults have a fair amount of priority, and there's obviously a wide developmental range in between. And if there's specific things we can undertake so that there's across the lifespan, a systematic effort to think through equity.
Absolutely. And I think I just saw David Maas leave, and I'm going to give him credit in his absence. I'm
Don't
sorry.
worry, I'll pass it along.
Sorry for calling you out here for leaving. But, you know, David has really articulated an important dimension of the ISP refresh, the subcommittee on health equity, that we are uniquely poised to really have a smooth, seamless way in which we care for people literally from cradle to death here at Stanford Medicine. Again, because of our combination of incredible institutions, that we can literally make sure that there's a smooth transition between one and the next. And I wish David were here to articulate in his own words what he shared with us in the ISB subcommittee. But you're absolutely right. I think there are ways in which we can make it easier for people to feel like once they are patient here at Stanford Medicine, they're literally a patient all throughout their lifespan.
Thanks so much. And I'm going to try to see if I can figure out how to switch the camera back over. Yep, there I am. Okay. So I want to just take a moment to just thank you for all of your time this morning. I will be sharing David's, for those of you who don't know, my boss. So I will let him know that he was called upon. And so once again, Dr. Sackey, thank you so much for all of your thoughts, your wisdom, and also all of your work over the many decades and the many more to come. So thanks again. And that'll be this grand round.